Welcome to another PrecisCa tumor board. We've got several cases to discuss today, very good cases with some challenging questions and some interesting decision-making pivot points throughout the care of the patients presented here. I just want to start with some introductions before we get started. I'm Dr. Benjamin Levy, and I'm associate professor at Johns Hopkins School of Medicine. I'm a lung cancer specialist and also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. We'll just briefly go around and I'll allow each of you to introduce yourself. So I'll start with Dr. Keston.
Yes, I'm Larry Keston. I'm a radiation oncologist. I'm a clinical professor at Wayne State University in Michigan. I work for Genesis Care, and I am the medical director of radiation oncology in the Michigan region. I also am the director of, I'm the chair of thoracic radiation oncology for the American Board of Radiology.
Hi, I'm Dr. Jack West. I'm a medical oncologist focused on thoracic oncology. I work as an associate professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. Happy to be here.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology at Memorial Sloan Kettering Cancer Center. And I'm also a professor of radiology at Weill Cornell Medical College and a vice chair for education at Memorial Sloan Kettering Cancer Center in radiology.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
68-year-old male, former smoker, 50-pack year history of an enlarging right upper lobe nodule, undergoes a lobectomy and mediastinal lymph node dissection for radiographic T1B-N0, stage 1A2 lung cancer. We've got an incidental N2 on this case. So we have a T2aN2 stage 3A adenocarcinoma. So it's pathological N2. PDL1 is 100%. Patient has completed adjuvant carboplatin pemetrexed, and the contentious question about the role of postoperative radiation for incidental N2. So the question is, in a patient with a radiographic early stage lung cancer found to have N2 during disease during mediastinal lymphadenectomy, would postoperative radiation therapy be recommended? We just had a case like this that presented our own tumor board, and we had to finish up because the conversation kept going on and on. We couldn't get to all the cases. So patient presents with a surveillance CT imaging given the extensive smoking history. So we're doing some CT screening here, which is great. Performance status, the ECOG is 0. He has a history of a myocardial infarction, ischemic cardiomyopathy, hypertension, OSA, some hearing loss. I guess that's maybe the reason he got carboplatin. We can talk about that. Social history is he's a former smoker, 50-pack year history, quit in 2017, previous alcohol and marijuana use, family history consistent with a mom with lymphoma and a father with prostate cancer. So had a lot of images, and unfortunately we've got Dr. Ginsberg to show us some of these. March 2018, 0.8 centimeter right upper lobe nodule, has a PET scan at that time that shows an SUV of 2.5, decided to be followed. Fast forward 6 months later to September 2018, the right upper lobe nodule went down in size, favored to be benign. Fast forward to January 2019, everything's stable. Fast forward to March 2020, right upper lobe now with 2 additional small pulmonary nodules that are less than 5 millimeters. And finally, March 2021, 3 years later, after the initial discovery of the nodule, we see that this right upper lobe nodule has increased in size. 1.3 by 0.8 was 0.4 by 0.3. PET scan is done, hot SUV of 11.9 without suspicion of hilar mediastinal adenopathy. PFTs are done, FVC of 96%, FEV1 of 87%, and DLCO of 71% predicted. Dr. Ginsberg, you're going to go through a few images with us. This is the start of it all, March 2018 and September 2018.
So in March of 2018, we see this 0.8 centimeter lung nodule, which had some mild FDG avidity at 2.5. And then decreased, which is a bit unusual as we heard the history, that 6 months later, this nodule decreased and now measures about 0.4.
Okay, fast forward.
And again, we see this nodule is a little bit smaller, but a year later from the 2020 study, this nodule significantly increased from this 0.4 measurement to 1.3 cm in the longest axis. And at this point, its SUV is high at 11.9. So this is consistent with primary lung tumor.
Great. So the patient undergoes a right upper lobe video-assisted VATS with lobectomy and mediastinal lymphadenectomy. The pathology is consistent with a 0.7 by 0.6 by 0.5 poorly differentiated adenocarcinoma. Visceral pleural invasion is present. He has positive lymphovascular invasion. He has surgical margins that are negative. Unfortunately, the 4R lymph node involved that's dissected is involved by adenocarcinoma. So 1 out of 10 lymph nodes are involved. His final pathological stage is a pT2aN2 M0. He's a stage 3A. His PD-L1 is 100%. We can talk about the new relevance of that. And he gets full staging with a brain MRI afterwards, given the N2 disease. The MRI of the brain is negative. And the patient completes 4 cycles of adjuvant carboplatin pemetrexed. In a patient with radiographic early stage lung cancer found to have N2 disease during a mediastinal lymphadenectomy, would postoperative radiation therapy be recommended? Dr. Keston, I'm going to give this unfortunate responsibility to you to discuss potentially the evolving role of lack thereof or doing it versus not of giving postoperative radiation therapy, given some of the new data that we may have for N2 disease.
Well, yes, thank you very much. This is a highly controversial topic, as you're implying. First of all, I guess I would say that this is a relatively rare scenario now due to improved imaging with CT and PET, as well as more frequent appropriate mediastinal lymph node sampling prior to surgery. So it's a relatively rare scenario these days. But and it used to be more common in the past. There have been many trials that have looked at this over a period of decades, and they basically show that there's a lower likelihood of local regional recurrence if you add postoperative radiation treatment, but there is not an improvement in overall survival. In fact, some studies show a slight decrease in survival by adding postoperative radiation treatment. So I'm actually going to make this probably easy for you. I actually would not do postoperative radiation treatment for this case personally, but I'm not sure if I'm actually in the majority in radiation oncology when I say that. I just feel like this has been tested so many times. And now, of course, we have the most recent trial, the ARTIST trial from Europe, where they randomized 500 patients to receive surgery followed by chemo, and then randomized them to receive radiation versus no radiation. And that study showed a slight decrease in disease-free survival, but a slightly worse, overall survival in the radiation group. Not significant, not statistically significant. Very minor differences of a few percent for both. I think that, if a patient has extracapsular extension in a lymph node, then that's a reasonable consideration to recommend postoperative radiation treatment. If there are numerous lymph nodes involved, if there's there's 2 lymph nodes that are positive and there's only 2 that were sampled, obviously, then that would be a much more likely scenario where you would recommend it. In this particular instance, it was 1 lymph node out of 10, which is a reasonable sampling. It's short of, definite extracapsular extension. I wouldn't recommend postoperative radiation treatment for this case.
Yeah,
just my opinion.
Very nice summary. Lung art certainly did not do any favors for postoperative radiation for N2. I was on Twitter where I get all my medical information from, and there was this this survey of radiation oncologists and whether they routinely now recommend postoperative radiation therapy, and looking at the trends before the lung art data came out and afterwards. And it was interesting because some of the radiation oncologists certainly still, there were people who just didn't change their practice. But one of the things that it seemed to change, it seems for at least single station N2 disease, there wasn't a lot of enthusiasm. But for multi-station disease, there seemed to be still some fair uptake of radiation oncologists in this survey that would do it. So if this were multi-station disease, Dr. Keston, I think you said this, and would you be more inclined to do it? And then I'm going to let Dr. West talk about potentially swaying you not to do it, given the new indication that we have with potentially immunotherapy. And this is a moving target, but would the bulk or multi-station disease, would that push you over the edge?
It would make me more likely to recommend it, but it doesn't mean that I would necessarily recommend it if there was a very adequate lymph node dissection and no extracapsular extension and say 2 or 3 positive lymph nodes. It doesn't mean that I would recommend it. I guess I feel like if God forbid this is a localized nodal, what you're reducing is a likelihood of nodal recurrence, right? And if God forbid there is a nodal recurrence in the future, it's really not that hard to treat these cases like a stage 3 lung cancer case in that situation with concurrent chemotherapy and radiation treatment, followed by immunotherapy with a reasonable cure rate. And I think with just more modern approaches, unless there was a higher percentage of lymph nodes involved or extracapsular extension, I wouldn't recommend it. I think another problem with this for radiation oncology is, you're targeting something when we treat lung cancer in all other instances, we know exactly what we're aiming at. And in this instance, you do not know what you're aiming at. And therefore, you have to aim at a bunch of mediastinal lymph node stations. And it turns into a larger target that can cause more toxicity, especially in the long run for a patient who's already had probably a lobe removed. So I guess I would say it would make me slightly more likely to recommend it, but it doesn't mean that I would recommend it just because 2 or 3 lymph nodes were involved.
Okay. Dr. West, I'll give you the softball question here. We have a new indication. I think it's actually important to discuss. Walk us through how you'd approach a patient like this. Let's assume that Dr. Keston does not recommend radiation therapy, how you approach these patients in general, and what's, walk us through your therapeutic strategies here.
Well, I'll start by saying I really think Dr. Keston's summary was circumspect and very appropriate and spot on. And to me, the question of post-operative radiation, particularly for N2, was kind of like how we medical oncologists approached consolidation chemotherapy for stage 3 after chemoradiation for a decade or more, where we didn't let the ambiguous or complete lack of good data keep us from doing what we presumed was the right thing. But over time, the data just mounted and mounted that there wasn't a compelling reason to do that. And in N2 disease, we still have room to debate for patients where you really feel like your back's against a wall, the extranodal extension and multi-station disease where there may still be a role to individualize and debate this. It's not incontrovertible right now, but the lung art trial should have done nothing to increase anyone's enthusiasm for it. But I think another thing that is a common point is that it really wasn't until we saw the value of consolidation immunotherapy after chemoradiation that it really slammed the door on consolidation chemo, because we had something that, in contrast to the chemotherapy, had a clear, compelling benefit. And I would say that the adjuvant, either EGFR inhibitor therapy with osimertinib for EGFR mutation positive, or now adjuvant atezolizumab for patients at least with high PD-L1 is a very strong option to pursue. There is now an FDA approval based on the Empower 010 trial that looked at giving up to a year of every 3-week atezolizumab for patients who had undergone resection for 1B to 3A disease and had also undergone at least 1 cycle or up to 4 cycles of platinum doublet chemo. So that really fits for this patient. What I think is most debatable is maybe which patients who were eligible for the trial are strong candidates to actually get this, because the data were, I would say, very strong, with a very meaningful improvement in disease-free survival, hazard ratio of 0.43 for patients with PD-L1 expression of 50% or higher. In the 1 to 49% group, it's 0.87 for DFS, and none of this is talking about overall survival, which is too immature, and is, I think, likely to get at least somewhat diluted over time. So I would say, in my mind, that it is very compelling and appropriate to pursue this for patients with high PD-L1, and our work in patients with advanced non-small cell would say that even above 50%, it's not just a uniform population, that those with 90 to 100% are the best of the best. And so I think this patient has a far more compelling approach with atezolizumab as likely to remarkably reduce the disease-free, improve the disease-free survival. I think there's a very strong chance that over time we'll see that it improves overall survival as well. I'd consider that way more appealing than a radiation-based approach here, for this particular patient. I would still say that, as has come up in some of our other discussions, it's ideal to really clarify this patient doesn't have an EGFR mutation or ALK or something. This patient has a smoking history. I wouldn't say that's likely, but we have come around to the conclusion that patients whose tumor harbors a driver mutation, we can be faked out by the high PD-L1. I think that's not likely here, but just to be complete, I would feel extremely supportive of the year of atezolizumab, knowing that his tumor doesn't harbor a driver mutation.
Yeah, great summary and great point. Molecular testing still critical here to unearth potential drivers. And I think if we did find an EGFR, we'd both be more comfortable or actually want to give osimertinib versus adjuvant atezo. Those are both new approved agents in the adjuvant setting. So let's summarize this case and move on. Sounds like, Dr. Kesson, based on just a single nodal disease, into that you would not offer post-operative radiation therapy. You may be swayed, with the operative word may, if there was extracapsular extension or multi-station N2, but for this case, you would not offer it. And then I think Dr. West's important points, molecular testing on this patient, and then the new FDA approval that we received just a month ago or 6 weeks ago with adjuvant atezo would be relevant here, very relevant, given the high PD-L1 every 3 weeks for up to a year.
Dr. Levy, can I just make 2 quick points? It's such a perfect case to highlight 2 really important surgical things. Every patient who's undergoing lung cancer surgery, be it a wedge resection, segmental lobe, should have a lymphadenectomy. And number 2, this kind of case is a reason why lobectomies are the recommended treatment for T1B/C tumors, because we know that up to 20% of patients with clinical stage 1 disease will be found to have isolated, unsuspected microscopic metastatic disease, N1 or N2 nodes.
Yeah, great point. Great point. Things may change at the time of pathology, time of resection.